Okay, too early?
Yeah, go ahead.
Okay, good afternoon, ladies and gentlemen. Although there are very few in front of me because this is a first one for us, actually a second one, but this is going to be even more challenging than the first one. This is the first time that here at the Foreign Correspondent Club of Japan, we will try to, at least try, to have questions online for this press conference, this briefing by Professor Kenji Shibuya, who is in London. Thank you very much, Professor Shibuya, for your time and being with us. I don't know whether the people is seeing both of us in this moment. Anyway, Professor Shibuya is in London. He is the director of the Population Health Institute of the London King's School. And he is going to share with us what he has been already saying many times on the press in the recent days, criticizing sharply what the Japanese government is doing here, approaching the virus emergency. And I am here in Tokyo with my colleague and friend Teddy Jimbo, who we owe everybody this magnificent technological attempt. And well, let's start with, let me tell you just everybody something. We are going to listen to Professor Dr. Shibuya for about 15, 20 minutes. And then we will give space to the questions. Now we don't have a floor as usually, so we will take questions online by raising your hands on Zoom. I don't know whether we will able to do that, but we will try. Otherwise, we already have some questions submitted by colleagues and members of the club. And if any of you has other questions to submit, he can use the following email: news@fccj.or.jp. I repeat it, news@fccj.or.jp. Shibuya Sensei, dozo.
Okay, thanks very much for FCCJ for organizing this and also giving me an opportunity to speak out. So I'm a public health expert, and I'm not basically criticizing anyone, but I am just trying to give constructive argument to improve the situation in Japan. So let me just talk at the beginning for 15 or 20 minutes about my personal view on what is happening in Japan by using this slide. Right, can you see this?
Yeah, we can see it.
Is it clear? Okay, so I give just my personal view.
Thinking Japan response to COVID-19.
Exactly.
Yes.
Yeah, so I'm using this. So let me just give you a brief introduction. So the facilitator gave us a very nice introduction, but basically this is who I am. So I'm kind of professor and director of the Institute for Population Health at the King's College London, but also I'm kind of senior advisor to the Director General of WHO, but I'm also a member of the Scientific Advisory Committee of the Coalition for Epidemic Preparedness Initiative, which is called CEPI, and which aims to develop pandemic vaccine. And previously I was in Tokyo until March 2019 as a chair and a professor at the Department of Global Health Policy at the University of Tokyo. So I know many people working on this at the Ministry of Health and Labor Welfare, Foreign Affairs, Cabinet Office, and other people working on the ground every day. So my expertise includes public health, population health, global health, health systems, epidemiology, and statistical modeling. So that's who I am. And of course, usual disclaimer applies on this. All views expressed here are solely my own and don't represent the opinions of any entity, which I'm now or will be affiliated with. Okay, so this is my personal view. And so what I'm going to discuss with you today is just three things. One is, what can data tell us about COVID in Japan? Given publicly available data, what we can tell about COVID in Japan. And secondly, there's a clinic. It's basically a fever clinic, but in Japan, there is an outpatient center called Kikokusha Sesshokusha Gairai. So I try to translate it by my own, but I think it's nice to use literally translated terminology. So I copy and paste. I Google this term and try to find English translation. But one of the prefecture used this consultation center for recent arrivals and people who have been exposed case with confirmed COVID-19. So I will talk about this. And finally, my biggest interest right now, and also a concern as well, is asymptomatic and pre-symptomatic transmission. And there seems to be a huge a difference in terms of how to tackle this between physician and public health people. So that's the final part of my talk. So let's get started from what can data tell us about COVID in Japan. So, this is every day you might the website, which is nicely compiled, and the cases, number of tests, deaths, and many information. On your left-hand side, it's the number of tests and the trends. And according to this, number of tests usually only include the number of tests done at health centers, not private laboratories ordered through physician clinics. But every Friday, they add all the information from private laboratories on every Friday. So there's a very strange spike here. These are data added on Fridays. And surprisingly, this week, the number of tests done at health center is declining. I don't know the reason. On your right-hand side, this is number of cases. And if you look at the trend, these days, the number seems to be small. But given the number of tests being implemented, particularly, for example, the last data set is about 170 or something, just for health center. And we don't know the number of cases from the laboratory, private laboratories. So it's very hard to tell how these two data sets reflect the reality. And also note, on your right-hand side, number of confirmed cases, it's not basically sorted on the basis, the data of onset of symptoms. It is based on the data reported and also compiled. So in terms of epidemiological information, there seems to be lacking the very important information about the date of onset. And also, as you know, all the information compiled as set by fax. So everybody has to manually enter this data and compile. So even just looking at this, it's very hard to trace and track what is going on. Because of comparison process of data set and the definition behind these numbers, and also inconsistency between the number of tests reported. So we have to be very careful about interpreting this. Number two, although the Japan seems to be entering the explosive phase, but people argue that still we don't see so many deaths from COVID in Japan, so which may be a success of the Japanese response to COVID. But we have to be very careful of this because take an example of flu. So influenza. So the exact burden of influenza is very difficult to quantify because the majority of influenza cases are not tested, right? So and the influenza could trigger secondary infection, bacterial infection, and also of course exacerbate existing chronic condition like heart disease or other sort of chronic disease. So if somebody has heart disease condition and got influenza, not tested, died. Even then, doctor fill out this certificate, he or she died of heart disease. So from public health viewpoint, it's obvious that death from influenza or usual contagious infectious disease is often underestimated. So I'm not saying that we have to test everyone for the case of influenza. It's impossible or meaningless. But we need to estimate the real burden of food burden. To do so, there is a method called excess mortality estimation process. So it's basically estimate the expected number of deaths from influenza-related cause of death from previous years, and also estimate, get the observed mortality during the epidemic. So we take a difference. So we attribute that difference to excess mortality associated with food. And as you know, this year, and particularly my colleagues at University of Tokyo published in JAMA recently that influenza epidemic was already ended around mid-March. So I saw this information could be used to just approximate potential impact of death from corona using excess mortality. And on your right-hand side, this is the data from National Institute for Infectious Disease. They always track the influenza associated excess mortality. If you look at the most recent data set, there is a point here. This is the expected number of deaths from previous years, and this pink line is upper bound. So they estimate the uncertainty ranges, and this is the upper bound for 95% confidence interval. If the death is over this, of this line, like this, there is a statistically significant increase in excess mortality. And around mid-March, the influenza is over. And what we see these days, maybe, I'm not saying with 100% confidence, but maybe there is excess mortality from some infectious disease. And the magnitude would be at least up to 20, but at most up to 50 in Tokyo. So there seems to be some undiagnosed coronavirus deaths. It's not, I'm not hiding. I'm not saying that the people are hiding. No, this is the system. Death certificate of heart disease of someone who has never been tested. It happens very often. And also there is a reported growing number of deaths outside hospitals. Particularly in the UK, there seems to be a 40% increased deaths from corona if you look at deaths at the nursing home or deaths at household. So there are a growing number of cases like this in Japan. But finally, and it depends on the phase of the outbreak. So this is the data from the expert panel yesterday, and this is famous mathematical modeling by Professor Nishira. And depending on the type of intervention, 80% reduction in contact, or 65% reduction in contact, the curve will be different. So this is the actual curve, and these two, orange and yellow, is based on the reported, because there is a time lag, 2-week time lag between the onset and also reported. So basically, we are looking at this. But we are not quite sure. So if we are here, we will see more deaths to be reported, we expect. But right now, if you look at the data set, I'm not quite sure we are achieving 80% or even 65%. But on top of that, I'm not quite sure when these days are corresponding to date right now, and what is the current fitting curve from these latest data set. The problem is that all of these data are not publicly available. So there is no way for us to validate or even replicate or scrutinize. This applies to this national NIID data set. When I call them and ask for the background data set to be shared, and they said, we need to figure out a specific form, and it might take a few months for me to get these background data set. It's not a very super duper technology. It's very simplified way. Any student could do this kind of analysis, but basically we don't have access to this data. So at this stage, we can tell very little from this public available data set, but we can speculate that we are still, Tokyo, particularly Tokyo, is in the explosive phase. And even though the Japanese healthcare is very good in terms of access, the number of deaths will be expected to grow in the coming weeks. That's the only thing we can tell, but we need, really we need data, and also some of the working papers, and also assumption behind this approach. For example, particularly cluster control people are assuming that 20% of the cases are spreaders and 80% are not. But that kind of assumption should be carefully scrutinized or validated. But we don't have any information to do that. Number two, this 帰国者接触者 guideline. The reason why this is basically a consultation center or feedback clinic for those who return from foreign countries, or those who have been exposed or had a cross contact with infected people. This term really represent the core strategies of the Japanese response to the epidemic. So primarily they are focusing on 帰国者, border control, so those coming back from foreign countries, and those who are exposed to confirmed cases. Their focus is these two. Right? So this is the core, or has been the core, of the Japanese response to any epidemic. And this time they also use that approach. So border control and contact, and cluster control, as you know, these are two major approaches. And recently, there was a joint statement of the two professional society on ID infectious diseases. And in order to protect healthcare from confusion, they advised to restrict PCR test to suspected viral pneumonia cases among pneumonia patients who require hospitalization. So they restrict the testing a little bit more so that they can prioritize the severe cases to prevent deaths from COVID-19. So given the limited resources, capacity, PCR testing in Japan, and from clinician's point of view, it is extremely important to save lives. That's very reasonable. So from clinician viewpoint, and also viewpoint of ID specialists, infectious disease specialists, I think this is reasonable and legitimate, focusing on severe cases and save lives. Right? So limit the test to those who have very severe, symptom, and check the, cross contact, trace the cross contact, and isolate them. That's their strategy. But probably there was very shocking data released from the Keio University yesterday. And it's in Japanese, but 6% of asymptomatic patients with unknown COVID status were actually COVID-19 positive. 6%, okay? Of course, this is hospital-based data, and the 6% figure cannot be generalizable to the general population. But this shows even patient admitted to hospital, asymptomatic patient, asymptomatic meaning without symptom of COVID. But again, for example, they admitted because of the traffic injury or elective surgery or delivery or some sort of testing without any symptom of COVID. There are patients who are infected. So to me, it was very shocking news yesterday, because this is my biggest worry. Because focusing on the cases with major symptom and trace the cross contact, isolate them. That's the cluster control approach. But if you continue to do that, you definitely miss asymptomatic or pre-symptomatic mild cases within the community. And obviously, there are many widespread community infection which cannot be traced. And from these community transmission, there are growing number of hospital transmissions, which actually, so people, initially there was argument whether we should expand the test or not. And the usual argument is that if you expand the test, you will see more patients. That will definitely overwhelm the hospitals. But if you look at the reality, that was the opposite. Because if you limit the test, you miss all the community transmission, asymptomatic cases. That will lead to the hospital transmission, and all the major hospitals suffering from this. And now, because the explosive phase, we see more patients to come. So I'm very worried of this current situation of healthcare. So it's reasonable. For example, a major professional society, this is the Neurosurgical Society, they also issued a statement requesting that PCR tests should be done under the national insurance scheme for a asymptomatic patient in order to prevent hospital transmission from COVID-19. It's serious. But most of the university hospital, big hospital, I think they are doing PCR for admitted patient, but they are not paid by national insurance. They are doing out of their budget, right? So they're asking, so that they can do PCR under the national insurance scheme. I think this is a very also legitimate request, because hospital transmission is a big thing. Once it happens, they have to shut down. So, and also recent study. So I'm very concerned about the lack of focus on asymptomatic or pre-symptomatic cases right now, which is widespreading in the community now. So there's a very interesting recent study in Italy, and this is a study focusing on small town, which were affected COVID earlier, and they did a 2 serial population-based survey, and they, according to this, they did the population-based survey twice. Up to the first wave includes 86% of residents, and second wave include over 70%, quite a large proportion of the population. It's not a big town. And when the COVID happened there, the mayor, implemented a lockdown. And after the lockdown, COVID prevalence reduced from 2.6 to 1.2. The lockdown was successful. But the point here is when they are doing the survey of the majority of residents there, not only they looked at the demographic data, but also demographic characteristics, but also they have a detailed information about clinical manifestation, presentation, and of course the nasal swab, and also viral load, and they have all these detailed information. So according to them, all the transmission happened 43% across 2 surveys, asymptomatic transmission from asymptomatic cases, right? And also, if they looked at the viral load from the swab, and there was no statistical difference between symptomatic and asymptomatic infections. Of course, viral load doesn't necessarily mean infectiousness, but this is very important information. Because usually, contact tracing, we focus on those who have symptoms, but there is a potential, the infection from these asymptomatic and pre-symptomatic cases. So my final part of my presentation is about this, asymptomatic and pre-symptomatic transmission. And there is, two opposing views on this, between physician or infectious disease expert versus public health perspective. For the physician working at the hospital, clinical perspective is very important. Their primary objective is to reduce the disability and save lives of a patient. So it's natural from their viewpoint. Forget about mild cases or asymptomatic cases. Focus on those cases with major symptoms and save lives. And so therefore, if the number of testing is limited, focus on those who have symptoms. It's very reasonable. But from public health perspective, unless you tackle not only the symptomatic cases, but also quite a few asymptomatic and pre-symptomatic cases, we cannot contain this epidemic. So now I think Japan, we need right now discussing when to finish the state of emergency situation, even though, as you know, Japan is not implementing lockdown. I would say kind of mild lockdown to enhance the social distancing, but there should be an ongoing debate about it. But in other countries like UK, continental Europe, the US, there have been much debate on that, when and how to lift the lockdown. So recently, the US proposed phased approach. So not lifting lockdown completely, they implement a phased approach to lift the lockdown. And also they suggest there will be an intermittent lockdown depending on the resurgence of the transmission. But as you know, lockdown costs a lot. Economy will go down, social disruption, although we have a new way of life, online, so it's getting better in terms of healthcare because online, consultation is being approved thanks to Japan Medical Association's great decision. But flip side of it, there are many people who are suffering, not just economically, and also the people, particularly vulnerable population, and they suffer most. So lockdown costs a lot. So we need to think about not just intermittent lockdown, but we need to carefully think about how to avoid lockdown. Because the major purpose of lockdown is to protect the health system, right? So to protect the explosive surge of the cases and to suppress this so that the healthcare can accommodate the surge of the patient, particularly intensive care, because as you know, Japanese intensive care capacity is very limited compared to other countries. So that's the major purpose of lockdown. But if you repeat this kind of intermittent lockdown strategy, that's the most debated and feasible approach. People are talking. But if you look at this is just a simplified diagram. So this is Japan, and this is simple SIR component. These are not infected, but susceptible. And these are people infected. And we have asymptomatic or symptomatic cases. And right now, the current Japanese approach is focusing on these people, some part of symptomatic cases with pneumonia. They focus on that. And these are people who are recovered from infection. Whether they will have a lifelong immunity, it's a question mark, but they may have some sort of immunity against COVID-19. And if their immunity doesn't last long, they will go back to susceptible. So right now we are focusing on this. Japan is focusing on this. And of course, border control. But my hunch is this is the right thing if you really focus on from physician viewpoint and just focusing on major symptoms and save lives. But from public health viewpoint, unless you tackle the component segment in red, it's very hard to end this epidemic. So over the past week, there are two very interesting proposals, one from the US, Harvard Group, and one from the UK public health expert. Many of them are my friend. And on your left-hand side, and this report proposed massive scale-up testing and also tracing with apps and supported isolation. Basically, what they are proposing is a simplified, basics of test and isolate strategy, but massively. It's massive. But on your right-hand side, they are arguing for universal testing. So testing everyone in the population.
Professor, I'm very sorry to interrupt you, but
I finished
yeah.
in one slide.
Please wrap up. Yes, thank you.
Yes, sorry.
Thank you very much.
So we have to carefully think about, we need to do scenario analysis. So and there are a bunch of approaches. So business as usual, we stick with the cluster control, or current managed herd immunity, so lifting lockdown or repeat lockdown, intermittent lockdown, or universal testing or massive testing, or a bunch of opportunities. And for scenario analysis, we have to carefully think about this for the exit strategies. So I've stopped here. Sorry, it took long.
Thank you very much, Professor. Very interesting indeed. Very important points. I hope we can develop them now with the questions. Let me repeat how we are going to proceed in this premiere. Please raise your virtual hand on the Zoom where you're connected at, and my friend Jimbo will signal me who raised the hand, and I will give the microphone. And the person who raised the hand will be on the screen, right?
Okay. Okay. Let's go with Nakano-san. Hirofumi Nakano.
Okay.
Nakano Hirofumi.
Nakano Hirofumi from Office Liberté.
Thank you.
Okay.
Thank you for briefing, Mr. Shibuya. My name is Nakano. I'm a freelance. Actually, I have two questions. The first question is, if the number of PCR tests increase and other tests, such as antibody test and antigen test are available here in Japan nationwide.
He's the first one to raise.
How do you think the number of confirmed cases here in Japan will change?
So can you repeat again? I couldn't hear well.
Oh, okay, from the beginning.
So first question is fine. So you're asking whether we should
this one is the whole question. I mean, the first question.
Okay. Sorry.
Yeah, if the number of PCR tests increase and other tests such as antibody test and antigen test are available here in Japan nationwide, how do you think the number of confirmed cases here in Japan increase or change?
I think, as you know, the more testing, the more cases, that's obvious. But also currently, we're in the explosive phase of transmission. So, there are two ways we observe the increase in number of cases because of the number of testing increases, but also number of infected cases are rapidly growing. So I think if you do more PCR to test and identify those infected, we see more number of cases. But if you, for example, if you do a simple math from the data from Keio University, so it's a hospital-based bias data set. So 6% prevalence among the asymptomatic admitted patient. So if you take the simple 95 confidence interval from, because the sample is not that big, 60 something. So confidence interval is wide. So maybe from 2 to over 10. So if you take 2%, just for safe side. And because PCR sensitivity is up to 70%, so maybe just say 3% of the population. If you apply that figure to Tokyo, you will figure out the potential number of cases now.
Okay.
And the antibody test is very important to understand how many people are already infected. So I think these two should be measured, particularly in the exit strategy, because if you expand the PCR, you understand real-time reproduction rate, right? So you monitor how many people you get infected from one infected person. And if the number is below 1, you can lift and rock them. But also, it's very important to understand the prevalence of cell prevalence of antibody to figure out how many people are already infected. So these two measures are very vital for the next phase.
Okay.
What about antigen test?
Sorry?
What about antigen test?
Oh, you mean IgM?
Yeah.
Yeah, both are antibody tests, right? It's IgG is IgM.
Yeah. So these are two different things. Can we consider them? I mean, can we consider these two different tests are pretty much the same thing?
It's both an antibody test, but IgG and IgM are slightly different. IgM for the early sign of infection, early phase. IgG for past infection. But I think PCR will be much more powerful in terms of diagnosing the current infection. But you can use for supplementary information, but you have to be very careful about variety of the testing kit.
Thank you very much.
Thank you.
Gerold Friday from Bloomberg is next.
Wait a minute.
Are you there? Yes, go ahead.
Good.
We can't hear you.
It's muted.
Yeah. Okay.
Can you hear me now?
Yes.
Yes.
Okay, thanks. Thanks very much for your time. I just wanted to ask a question about the difference between Japan's approach and South Korea's approach to handling the virus. Given your background and your experience, what explains the different strategies that these two countries have taken? Is it just down to obviously Korea had a very different experience in that there was the explosive growth thanks to the religious group that caused a rapid spread. Has that informed different strategies?
Mm-hmm.
And would it be technically possible for Japan to ramp up testing in the dramatic way that South Korea has done? And if not, what explains that? Does it come down to the fact that Japan does not have a center for disease control like South Korea or the US do?
Okay, so very good question. So basically, the success of Korea so far is primarily due to their, they have been sticking with the basics, i.e. test and isolate, right? So whatever the phase would be, the basic strategy to tackle any epidemic is test and isolate. And South Korea has been preparing for this kind of pandemic because of the experience of MERS and of SARS. So for the past 2 decades, they have well prepared for this kind of situation. They have already legislated the use of apps to trace the people. They have already legislated. And also they know from the experience from SARS and MERS, the only way to identify the potential infection is to expand the test. So the major difference between Japan and Korea is that basically whether we should stick with the basics and basic strategy, that is test and isolate. On the contrary, Japan focuses on border control and also cluster approach of those who have major symptoms. And therefore, they missed the asymptomatic or pre-symptomatic community transmission. So whether it's feasible in Japan, of course, it's feasible. And people say, because Japanese PCR test capacity is very limited because of the capacity at the health centers and their associated laboratories. But there are many PCR machines at the universities or any laboratories which deal with genetics, and of course, private companies, laboratories. And so if you count the total number of PCR machines and those working on that, I think we can manage to expand massively the testing capacity. And this is national emergency. And there are many laboratory technicians who are staying at home. But we could ask them to come back, of course, taking social distancing, and like a night shift, day shift, 24 hours a day, 7 days a week, we can massively increase the capacity for PCR testing because that's the priority.
Okay, let's go next.
Thank you. The next one is Shigenori Kanehira from TBS.
Yes.
Go ahead.
Thank you for your briefing, Dr. Shibuya. My name is Kanehira, working for TBS Tokyo Broadcasting System. My question is, I have two questions. Japanese government said that they will consider during the Golden Week holidays whether to extend the country's state of emergency after the holiday period. What's your opinion on ending the state of emergency at this point in time? The second question is, I just have a very breaking news. One of the Japanese famous actress, Okae Kumiko-san, died due to the coronavirus infections. And considering the present state of the country, Japan, what do you think the Japanese people can do prevent further spread of COVID-19?
Okay. Are you working at home or in the office?
In office.
Please go home. So that's the most important things you have to do, we have to do. So, you know, I don't think you can lift the current state of emergency in a month. And if you lift it, and if you lift at the time of Golden Week holidays, it's a disaster. So I don't think it should be, the lifting should be postponed. But of course, we need to carefully look at the data. But as I said, public available data, we cannot say anything, not much. So I think it's important for the government and the expert to share that kind of data set so that we can understand what's happening. The secondly, and it's shocking because the lady is very famous MC on TV every day.
Yes.
And how old was he?
63.
63. So, as I said, there's already a community-wide transmission. And then again, up to 3%, that's a lower end estimate of population might be infected already. Huge number. 3% or 2%, I don't know, maybe less, but even that older, huge number of people already infected. So it's not a surprise. Even you right now, or me here, may be infected. So best approach is stay at home. Not just to stay away from 3Cs or night cluster or bus. No, stay at home. Avoid commuting by train. It's the usual basic stuff. Stay at home. Of course, you need to go out, do some exercise by taking social distance and keep fit and sleep well, but basically stay at home.
Thank you. Next one is Ilgin Yorumats. I'm sorry if I don't pronounce properly your name. Go ahead, please.
Thank you. Thank you, Professor. And yes, my question is also about testing. And I was just wondering if you can clarify this rate, the test positive rate. I believe it's the number of infections confirmed by the test over the number of tests, total number of tests. Is that correct, first of all? And also, the number that test positive rate seems to be for US, for example, almost 20%. For UK, where you are, it's almost 30%. Whereas in South Korea, it's about 2% because, of course, the denominator South Korea, they tested so many people. So I have listened to everything you said, and I'm wondering if the Japanese government can at least increase the tests to such a level that in South Korea, for example, it's almost more than 1% of the population anyway. But in Japan, I think, I haven't checked the numbers as of today, they haven't tested even not 1%, but 0.01. That's like 1/10,000. I mean, it's so low. The test rate is so low. So do you agree with that? Are you aware of this test positive rate? Can you explain?
So you're asking whether or not I agree with your observation. In terms of definition, it's obviously confirmed cases or the number of tests being done. But as I said, the cases reported here today in Tokyo is not necessarily the number of cases reported 2 weeks ago. So it's a number of cases compiled as of today, right? And also number of tests, it's just for the testing, overall testing from health centers. And on Fridays, they add on top of that a total number of tested during that week in Tokyo. So you have to be very careful with the calculation. But basically, the definition of it is correct. And the currently 40, 30 figure is very high. So we are not expanding tests enough. So as UK is ranked behind us in Japan in terms of testing capacity. But although they are expanding rapidly, and also they are now thinking of home-based PCR testing.
Patrick.
So yeah, quality is okay, but also we have to the reason why the number of tests is not increasing is because two Professional Society of Infectious Disease revised the criteria for testing, more strict, restricted test and criteria, because unless you have pneumonia, they are not allowed to get tested. It's clinically, reasonable, rational to save lives, but public health viewpoint is the opposite. The purpose for us is to contain the transmission, of course, by saving lives. But to do so, we really need to massively increase the capacity and also testing the number of tests.
Okay, let's go
Yes.
to Patrick Walter.
Patrick Walter from Frankfurter Allgemeine Zeitung.
Hello, thank you, Dr. Shibuya. Patrick Walter, Frankfurter Allgemeine Zeitung, German newspaper. I have two questions, if I may. You said that there is possibility to raise the PCR testing opportunities in Japan. Do you have any guess what number could be reached on a daily basis? I think South Korea says they can test about 20,000 per day. And I just wonder if you have any idea what might that number be in Japan. And the other question I have is, obviously your strategy seems to be, or your proposal to Japan is test, and try to see how many asymptotic or these cases you have in the population. Where do you see the red line? We hear very much here that the medical system is at the verge of collapse. Where do you see the red line? How many patients might be treated in your point of view in Japan before the system collapses?
On the first question about the appropriate number of testing service capacity, because I don't know exactly how many PCR machines available, and also the laboratory technicians right now, because health center-based testing capacity is very limited, as you know, because they have many things to do other than PCR test. So if we expand the capacity in the lab tech and governmentize all of them across Japan, we can boost the testing capacity. Of course, the specimen and also testing equipment will be an issue, but I think that's doable. And right now, Prime Minister has promised to increase the testing capacity up to 20,000 per day. But that's not enough, because if you need to really want to contain to avoid lockdown, the testing capacity must expand to 100,000 per day. 100,000. And we have to be very careful. So we need to be very creative, innovative about the way we implement the test. One possibility is home-based testing service. And of course, there are issues of how to swap for general public to do. But there is ongoing discussion about saliva-based testing as well. And there are a bunch of new testing kits, which is doable, feasible, at the lower cost. So we should go beyond the usual way of thinking and Japan should take a lead on that. And the second question is about the medical capacity, right? So my biggest concern is it's already collapsing because of hospital transmission, but B, because of explosive surge patient to come. So I suspect I think Professor Nishiwa is also estimating the number of potential patient. And of course, the ministry, we should have the number of ICU capacity. So I'm not quite sure because the number is not released, but it is about the particularly medical healthcare in Tokyo and Osaka is overstretched. And I see every day from the ground, it's collapsing. So I'm very worried. I can't say the actual number, up to how many patients we can accommodate, up to how many severe cases the healthcare system should accommodate. But that should be carefully monitored. And I think that should have been already estimated. But I don't have that number.
Okay, thank you.
Professor, we have a question now from Reuters. Rocky Swift, go ahead if you're there. Okay.
Thank you. Can you hear me?
Yes.
Thank you for your time, Dr. Shibuya. It's 2 months now after the Diamond Princess quarantine situation, and now we have another cruise ship related outbreak in Japan. So I wondered if you could comment on that and what it says about the government's ability to learn lessons and adapt to handling this kind of outbreak. Thank you.
Thank you very much. So Diamond Princess cruise ship instance is a kind of exceptional one because it's a massive cruise ship and it was first time for Japan to tackle this. So there must have been a bunch of trials and errors. And the way on post hoc basis, the way they handled was not necessarily appropriate. And I think it is extremely important for the government to carefully scrutinize and learn lessons out of that. But right now, the situation is totally different. It is a community transmission, which has not been tested, and that is spreading to hospital. And so I'm very worried because this could have been prevented. I don't want to say, on a post hoc basis, we should have done this, we should have, done that. It's easy to say, but still, the South Korea, some previously I answered the success of South Korea. They stick with the basics, test and isolate. That has to be done. Wherever you are in the epidemic phase, test and isolate is the very basic strategy. The older countries follow that advice from WHO, particularly test and isolate. Taiwan, Singapore, right now, Singapore have imported cases, so they did a lockdown. But before that, they did very well. And South Korea, and of course China. And so basically, the lack of testing was the biggest problem so far. But area, cluster control was very successful. For example, in Hokkaido, when the epidemic was very small and localized, and it was easy to contain. But big cities, it was virtually impossible without testing.
Thank you.
Some questions on the chat. Oh.
Here, he would like to, if possible, to see again your last slide. But his question is why Japan is so reluctant to expand testing. Is it a mistake or something more sinister? Some people say there are vested interests in trying to keep testing within the NIID. Do you have a view on this?
I usually don't buy any conspiracy theory, but the fact is, you know, and as I said, there are two different views on this. So NIID consisting of basic scientists and some very super great ID expert. They focus on more on the clinical approach, save lives, focus on severe cases and save lives. And of course, the NID cluster group, they are focusing on that approach. But given the fact that there is a widespread transmission due to asymptomatic, pre-symptomatic cases, you know, from public health viewpoint, we really need to expand the test. So people, you know, usually say obstacles are capacity, but as I said, if you expand the testing capacity, not just to health centers to universities, laboratories, private sector, it's possible. But also there is a shift from health center-based to physician-oriented, physician-led testing services. Particularly Tokyo Metropolitan Medical Association is now expanding and setting a PCR center, fever clinic and drive-through, walk-through type of testing services will be implemented very soon. So I'm hoping that approach will be expanded across Japan and boost the number of tests so that we understand more accurately what's going on the ground.
Professor, I think we have not much time anymore, but let me give the microphone to my colleague Jimbo, who is the co-chair of the professional activity committees. Please, Jimbo, fire your question. I guess it's going to be the more
Sure. Thank you. Shibuya-sensei, this is Terry Jimbo, the Video News. I guess I have asked questions in English to Shibuya-sensei. Professor Shibuya, I saw you saying in a Japanese TV that the actual number of people who are infected in Japan is probably as much as 10 times of that of the official figure. Do you have any basis for this 10 times estimation that you mentioned on Japanese TV?
Yeah, so it's based on the sensitivity, specificity, and also the ratio of symptomatic and asymptomatic. So it's just a rough estimate. But given the recent data from other countries about the ratio between observed number of cases from PCR versus a seropositive antibody testing, seroprevalence, the difference would be the factor of 20 up to 50, right? So 10%, the factor of 10 is kind of lower end.
It's a lower end.
Lower end.
It could be more. It could be more, you're saying.
But as I said, if you look at the data from Keio University Hospital about asymptomatic cases, and as I said, it's a small sample and facility-based, obviously biased data, and you can just apply that figure to general population. But if you just a quick, example or illustration, so it's 6% and a very small sample, and confidence interval would be probably 2% to over 10%.
Right.
And take example, the PCR, very good PCR specificity is 70%. So maybe at the lower end would be 3, 4 or something. Let's take a very low end for safety, 3%. Apply that figure to Tokyo metropolitan area. How many people were infected without being noticed? So just an illustration. I'm not saying that is true or not, I don't know.
Right.
But just simple calculation will give you a figure. How many people are infected right now?
Okay.
Thank you, Professor. Let me ask you just a final question. I am from Italy, and the Italian situation is very, very, very serious. You stressed twice tonight the basics, which is test and isolate. I think many countries have followed these basics, including mine recently, but in Japan, how would you concretely enact these basics? Because up to now, everybody that has been found positive basically has been put in a hospital, but now they are sent out in hotels rooms. Do you think that people in a hotel room can be isolated enough that they are safe? And we are.
Well, we have to be careful. Even mild cases turned out to be very severe all of a sudden after 1 week or 10 days after the onset of symptoms. So we have to watch out even for the mild cases. But I think sending mild cases or let them stay at home or at an alternative facility would be a good one. But so there's no point to argue that more tests will have more patients. Because, for example, asymptomatic cases, even if you find out, they don't have any symptoms. They just will stay at home or hotels. But the important thing is for them to understand their infectious status and stay away from others. So expanding testing will not necessarily increase the number of patients anymore. So we have to really expand the test to suppress this transmission, particularly among asymptomatic and pre-symptomatic people as well.
He wants to ask the last question.
President says.
President Khaldun would like to ask the last question.
Okay, no problem.
You ask directly? Yeah? Please, go ahead.
Go ahead.
I was not ready to be online. I thought Pio will ask this question. I am for Panoramic News and Arabic media. There are not conspiracy theory, but there are some wild theories that certain races are less vulnerable or less vulnerable for the virus, and they say some studies in the Middle East, they say it proved that people had a lot of contacts with Chinese, and they developed a lot of flu-like disease, but they never died, but they could recover. And they say some races might have more immunity, more resistance to the virus. Do you think that's possible scientifically or in race-wise? Thank you.
I'm not considering ethnicity will play a major role, but I think it's more on the personal characteristics, like age or condition or pre-existing condition, and of course, the environment and healthcare system as well. So we have to carefully look at the potential for antibody, how long it will last, depending on the population, age, or depending on the characteristics of the people. So we have to wait for the more antibody testing. So at this stage, I'm not quite sure that race will play a role on that. Might, but major role will be more on the personal characteristics, age, or pre-existing condition that may play an important role.
What about dogs, Professor? We heard your dog barking.
Sorry, you're home-based.
Are they not infected? 2 cats have been infected.
There are news that dogs should also take a social distance.
Okay, Professor, thank you so much. We have the custom to issue a 1-year membership, honorary membership of our club, but I doubt that you can show up right now, but it is valid for 1 year. So we all hope to see you here and welcome you our bar for a drink with us.
That'd be great. Or even online drinking would be great. Thanks so much.
Online drink.
And thanks to everybody who were connected. Thank you for Teddy Jimbo, for his huge technical and editorial work. And thanks to all the employees of the Foreign Correspondent Club that have been sitting here in a kind of war zone. Thank you so much. And until next time, we will have next week. Can we announce who we're going to have the next press conference?
Oh, yeah.
Can we announce?
Well, we have a few more lined up. So let's.
Okay. Anyway, stay tuned with the Foreign Correspondent Club of Japan in Tokyo. Thank you very much.
Thanks
very much.
Thank you, Pio.